Hi, I'm Alex. This is Chapter 23, Gynecological Emergencies. So to get started, women are uniquely designed to conceive and give birth. If you didn't already know that, you do now. Because we have fancy equipment to conceive and give birth, we have problems that men don't have. Here we have external female genitalia, and the big part that you should take away here is that it's not all vagina. So a lot of people are not clear on that. Most people think that the entire thing is called a vagina. However, it's not. So if you are referring to the outermost portion of the female reproductive system, then yes, that is the vagina, and you can see it here on the diagram. If you are referring to the urethra, call it the urethra. If you're referring to the labia, call it the labia. If you're referring to the entire area, then go ahead and refer to it as the vulva. It's kind of a, if you're not sure exactly what to call it, the vulva is the term for the entire area. Inside, so internal anatomy, you have ovaries. So there is an ovary on each side of the lower abdomen. Each ovary produces eggs, or ovum. The fallopian tube carries or connects the egg to the uterus and carries the egg. Connects the ovary to the uterus and carries an egg. The uterus is a muscular organ where the fetus grows. And quick little fun fact about the uterus is that during childbirth, the uterus can deliver about 600 pounds of pressure per square inch during contractions. So if a woman was pregnant and unconscious, or maybe in a coma, her uterus could actually deliver the baby all on its own, without any help from the mother, which is just incredible to think that you have an organ in your body that not only can support and help grow life, but it can also deliver it kind of all on its own. It's kind of amazing. Again, the vagina is the outermost cavity of a woman's reproductive system. It is not the entire thing. It is just the opening. Here you have another diagram. So here you can see the ovaries and how the fallopian tube carries the egg or the ovum into the uterus. The uterus, you can see how thick that muscle wall is. So during pregnancy, the whole thing gets much bigger and gets much thinner, but it's still a very, very muscular organ. The cervix is kind of the bottom-most portion and the opening to the uterus, and then from the cervix to the outside of the body, you have the vagina. So ovulation and menstruation, that's period. So this is something that starts happening during puberty. Generally, somewhere between 11 and 16 is when women start ovulating and start menstruation. The very beginning is called menarche or menarche. I've heard it pronounced both ways. But as long as you know what it is, it's the onset. It doesn't necessarily matter how you're saying it. Ovulation and menstruation continue until menopause, which happens sometime in later adulthood, somewhere in the 50s, generally speaking. Each month, one ovum is released into the fallopian tubes. This is called ovulation. The process of fertilization begins in the vagina. So for those of you who had abstinence-only sexual education, this is sex. So this is how it happens. It's a miracle of life. So sperm is deposited from the penis into the vagina. Once it's in the vagina, sperm flows through the cervix, up into the uterus, and then up into the fallopian tubes, where it then meets the ovum or the egg. Most people think that fertilization generally happens in the uterus, but it actually happens in the fallopian tubes. Once that ovum or egg is fertilized in the fallopian tube, then it travels down into the uterus, where it will implant in the lining. If fertilization doesn't happen, Within about 14 days after ovulation, the lining of the uterus begins to separate and menstruation occurs for about a week. So the material that's coming out is actually the lining of the uterus that your body produced to um, facilitate a pregnancy or to facilitate that fertilized egg that never happened. So causes of gynecological emergencies, they vary. They range from sexually transmitted diseases to trauma. Just kind of ask your patient what's going on, kind of go from there to determine what's going on. Pelvic inflammatory disease, this is a big one. So, so this includes the uterus, ovaries, and fallopian tubes. PID or pelvic inflammatory disease occurs almost exclusively in sexually active women because that's one of the easiest ways to get bacteria up in there. Just because a woman has PID does not necessarily mean she's sexually active. It's just you're more likely to get it if you are sexually active. It can result in increased risk of ectopic pregnancies and sterility. So when you have this chronic inflammatory disease, you have inflammation and scar tissue that form in small passages like the fallopian tubes. So when you have a narrowed fallopian tube, the fertilized egg gets trapped in the fallopian tube. When it is trapped in there, it eventually will just adhere into the fallopian tube. So it attaches in that tiny opening and then begins to grow and develop. Unfortunately, fallopian tube is not going to stretch. It's not designed for that. It's not a uterus. It's not the best place for it. So it becomes a big medical problem. It's a life-threatening emergency. The term ectopic pregnancy is when that fertilized egg adheres somewhere outside of the uterus. It doesn't have to be in the fallopian tube. It just is more commonly in the fallopian tube. Now, likewise, if you have enough scar tissue that it completely blocks the fallopian tube, then the woman is going to be sterile. Most common sign of pelvic inflammatory disease is generalized lower abdominal pain. That is a test question, so make sure you remember that. It's diffuse in nature and it's just general. It's not a specific spot that's painful. It's just kind of the whole area is painful. So STDs, sexually transmitted diseases. They lead to more serious conditions such as pelvic inflammatory disease. Some of them are treatable, some of them are some of them are treatable, but will stay with you forever. And then others, you can actually get treatment and have them go away. Chlamydia is one of the most common. Unfortunately, there are usually mild or absent symptoms. So when you have it, there's a good chance you don't know you have it. And if you don't know you have it, then you're going to be spreading it if you're not being wise and protecting yourself during intercourse. It can spread to the rectum. So it doesn't necessarily have to be within the vagina or in the genital area. It can also go to the rectum and within the urethra. Once it's up into the internal areas, it can progress to pelvic inflammatory disease. Bacterial vaginosis, this is, I think of it as a yeast infection. So very, very common. It's actually the most common vaginal infection to afflict women. If untreated, it can progress to premature birth or low birth weight in pregnancy, as well as pelvic inflammatory disease. Pelvic inflammatory disease is kind of one of those things where all roads end in PID when it comes to gynecological emergencies. Bacterial vaginosis or yeast infections are also much more common with pregnancy. So if you have a pregnant patient who is complaining of something going on in her genitalia, just be mindful that there's a greater chance that she can have a yeast infection than someone who is not pregnant. Gonorrhea, this is another one that's relatively common. grows and multiplies rapidly in warm, moist areas of the reproductive tract. Just like all of these other STDs, it affects men as well as women. And severe infections present with cramping, abdominal pain, nausea, vomiting, and bleeding between periods. Now, when we say bleeding between periods, we mean that outside of the expected time frame of menstruation, there's breakthrough bleeding. So bleeding that's happening when it shouldn't be happening. Causes of vaginal bleeding, abnormal menstruation. So like I said, breakthrough bleeding, bleeding that's happening when it shouldn't be. Vaginal trauma, ectopic pregnancy. Ectopic pregnancy, again, that is when a fertilized egg implants or adheres to an area outside of the uterus. Spontaneous abortion. So now this is not an elective abortion. This is the clinical term for a miscarriage. So be mindful and respectful and be careful when using this verbiage. However, it is the appropriate way to say miscarriage. It also kind of comes along with some negative annotations, calling it an abortion, especially because most people associate abortion with elective procedure, not so much a spontaneous miscarriage. So just be mindful in what you're saying and how you're saying it. Cervical polyps, these are growths that happen in the cervical area, which can also bleed. And then cancer. Unfortunately, cancer kind of happens wherever it wants to. So it's one of those things that it can happen there too. So your scene signs up. Scene safety, always number one priority. Gynecological emergencies can involve large amounts of blood, so make sure that you have the appropriate PPE to manage that. Involve the police if assault is suspected, and the mechanism of injury may be easily understood from dispatch information, such as sexual assault. Also be mindful that dispatch information isn't always accurate, so sometimes it'll go out as a sexual assault. In all reality, it was an argument, and there's no gynecological problem at all. And then other times it's dispatched as a trip and fall, and it turns out to be a sexual assault. So kind of take dispatch with a grain of salt. It can help guide you in what you're looking for and how you're going to prepare for your call. But also know that it's not always going to be 100%. So make sure you're asking the appropriate questions. For your primary assessment, form a general impression. Always evaluate airway and breathing, just like with any other patient. Pulse, skin color, temperature, moisture helps identify blood loss. Pale, cool, and clammy, you can expect a great deal of blood loss. If they're nice and rosy and warm, they're probably not bleeding out. Most gynecological emergencies are not life-threatening. They don't warrant a 911 ambulance trip, code 3 to the hospital. There's a good portion of the time they can drive themselves or they can have somebody else drive themselves, and that's perfectly acceptable. Investigate your chief complaint. Some questions are extremely personal. So, I mean, if I ask you about the last time you had sex, and ask for details like whether you used protection or you didn't, or if you knew this person, if you knew their sexual history, what kind of preventative measures you've taken, if you know that they're STD positive or negative, or even their status, or if they've been tested. Those are things that are really personal, and most people don't like answering those questions just in general. So if you're like in the mall food court, you're not going to get good answers. And it's really rude to be asking someone those personal questions when there are a lot of strangers around. Even when there are people who the patient knows, you don't want to be asking these personal, private questions. Get them to the ambulance and ask those questions in the privacy of your ambulance with the doors closed. So ensure that you're protecting their privacy and their dignity. So obviously, don't be doing a physical exam when there's strangers around. Don't be asking those personal questions. Get them in a private area. For abdominal pain, ask about onset, duration, quality, and radiation. Ask provoking and relieving factors, as well as associated symptoms. OPK or STI, make sure you ask those on every patient so you can get a better idea of what's happening. For vaginal bleeding, asks more specifically about the bleeding, onset, duration, quantity. So for quantity, most people are not going to be like, "Well, I lost about 200 milliliters of blood today." People don't quantify blood loss that way. At least most people don't. So instead, you can ask, how many pads have you soaked today? How frequently are you going through them? If they use tampons, you can ask how many tampons they've had, um, throughout the day. And associated symptoms such as syncope and lightheadedness, which are indicators of blood loss. So someone who's lightheaded, they're probably hypovolemic. Same thing for syncope. If they're passing out when they stand up, there's a good chance that they have lost enough volume that they're not meeting the needs. They're in shock at that point, or at least getting close to being in shock. Sample history, ask about birth control pills and devices. You can also ask about last menstrual period and STDs. Again, ask in a private location. And what type of birth control does matter. So, they tell you, you ask, is there any chance you could be pregnant? They tell you no. It's acceptable to say, how do you know? Are you on birth control? Are you abstinent? How do you know? Well, my partner and I use the pull-out method every time. Well, unfortunately, that's not a great method to use. So at that point, you can, you have more heightened. Um, there's a better chance that there's actually a pregnancy happening when they're using a less effective method than, say, being abstinent. If you're abstinent, you're not having sex, then there's no chance that you're pregnant. So it does matter. Secondary assessment. So pertinent secondary assessment findings, vital signs. Make sure you're getting all of them. In addition to just simply getting them, get orthostatic vital signs. So get their vital signs when they're sitting down, and then have them stand up, get their vital signs again. If they stand up and they have a drop in blood pressure and an increase in heart rate, then that means that they're orthostatic positive. And being orthostatic positive means that you're hypovolemic. You've lost enough fluid, either from dehydration or because of blood loss, that you're not able to compensate for something as simple as standing up. If they stand up and their vital signs are completely unchanged, then they're orthostatic negative, and blood loss is probably not a big concern at that point. Check the abdomen. So look, listen, and feel. So you're checking for distension. You want to see how firm it is, and whether it's like, do they look super bloated, or is their abdomen, small like normal? Or ask them, does your abdomen look normal to you? Does it feel normal to you? Because of course, we don't know who these people are. We don't know what their body normally looks like. So it's acceptable to ask them. Check for tenderness. And then tenderness, be specific. So when you push, is it tender, or is there rebound tenderness? So when you're pushing, it feels fine, but then when you release the pressure, then it hurts. So you can document that appropriately. So either, tenderness or rebound tenderness. For genitourinary, is there visible bleeding? Is there blood in the urine? And then, if it's necessary, you can visualize. And if there's blood at the opening of the urethra, then that's, not necessarily a reproductive problem, but could be, maybe a renal problem. Also, make sure that you're evaluating neurologic status. So checking for mental status, making sure that they're appropriate upstairs. For a physical exam, it should be limited and professional. So for the most part, you want to try to ask the patient um, what's going on and get a good verbal history. If based on their verbal history, you find a need to get a better idea of what's actually happening, then it is acceptable to do a, um, a visual exam. But it should be limited. It should be in a private area. You should have someone with you, like your partner, just to protect yourself. Anytime you're doing anything, visualizing genitalia, it's a good idea to have someone with you just to be a witness in case something goes awry somewhere else. So only examine if absolutely necessary. And again, if there's no need to look, then don't. But if they're kind of vague and they're not really helping you understand what's happening, and it appears that there's bleeding happening, then it would be acceptable to look. So for bleeding, visualize the bleeding, ask about the quantity and quality. So quantity, how many pads have they gone through? And then quality, what color is it? Is it, bright red and thin? Is it dark? Is it dark and lots of clots? Is it like a brown color? Does it have foul odor? You're asking questions about the blood as well as just trying to find out if there is blood. Again, use external pads to control bleeding. You can use gauze, you can use actual feminine products, you can use abdominal pads, you can use blankets, towels, kind of what you have. And if it's on the exterior, outermost portion of the vulva, you can have the patient apply direct pressure to help control bleeding, as opposed to you holding pressure, because that can be awkward for everyone involved. Observe for vaginal discharge. Again, you can ask your patient about vaginal discharge. Ask about syncope, fever, nausea, vomiting, any of those things associated or at least in addition to gynecological complaints can be significant and will increase your suspicion for something bigger going on. Your index of suspicion, that's the word I was looking for. For reassessment, repeat the primary assessment. There are very few interventions with gynecological emergency. Just get them to the hospital. It's pretty much all you can do in addition to supportive care. So like controlling bleeding or treating them for shock. Getting them to the hospital is pretty much what you're going to be doing here. Communicate all relevant information to staff the receiving hospital, including the possibility of pregnancy. For emergency care, again, there's not really a lot we can do, but it is super important to maintain their privacy. I can't stress that enough. Use sanitary pads to control bleeding. Again, it doesn't necessarily have to be like a feminine product or an abdominal dressing or trauma dressing. I mean, if you have a towel and that's what you have, then use a towel. Document the quantity. So how many pads did they talk about beforehand, and then what have you used to during transport to control bleeding? You're giving the hospital a better idea of how much blood this patient has lost. For external genitals, there's a very rich nerve supply, which makes injuries incredibly painful. So be mindful of that. And then again, external lacerations. So moist, sterile compress, and you will have the patient hold pressure on that area. We're not putting anything into the vagina. We are just simply catching blood externally. And then controlling external blood or external bleeding with pressure, and then sterile gauze or dressing or whatever you're using. Assessments and management of specific conditions. So for pelvic inflammatory disease, again, test question here, primary complaint is abdominal pain. Pre-hospital treatment is limited. Like I said, keep them comfortable, treat them for shock if necessary, get them to the hospital. There's nothing that we can do. The patient's going to need to be treated by a physician. Non-emergency transport is usually recommended, so don't waste an ambulance. Drive yourself or have somebody who is responsible drive you to the hospital or to your gynecologist's office. If they don't have any other means, then, of course, we'll take them by ambulance if that's what's necessary. For sexual assault, unfortunately, sexual assault and rape can be common. EMTs treating the victims of sexual assault face many issues. The biggest one is that you're likely to be the person they've had contact with after the assault. So you want to make sure that you're practicing compassion, understanding, professionalism, kindness, sensitivity. You don't have to baby them, but just be gentle with what you're doing and what you're saying. Try to get the best history that you can. We're not asking you to have them relive the experience over and over again, because ultimately it doesn't necessarily matter what happened, as it matters that you're there to help them psychologically. And then if there are any injuries, you can help them treat those injuries. Be aware of drugs used to facilitate sexual assault or rape. I think a lot of people are familiar with at least the fact that drugs can be used to facilitate rape. More often than not, they are medications that can affect the respiratory drive. So you want to make sure that you're being watchful and assessing respiratory rate, rhythm, and quality frequently to make sure that your patient hasn't stopped breathing on you. If possible, give the patient the option of being treated by a female EMT. So anytime there's anything that has to do with genitals, just in general, you should probably have an EMT of the same gender helping that particular patient. It's going to be a little bit more comfortable for everyone involved if you have someone of the same gender, especially when it comes to asking those very personal questions. For assault, again, your focus should be on medical treatment, psychological care of the patient, not necessarily like asking them exactly what happened in detail and what this person looked like that did this horrible thing to them. That's not where your focus should be. Your focus should be on what can I do to help. Preserving evidence. This is kind of a big one that gets a little bit of a backseat, but it is still important. If there is a reason for you to cut their clothing off, you need to be mindful of what you're cutting. So, for instance, someone was shot or stabbed. When you are cutting the clothing off, don't cut through holes that are already there. So if you have a gunshot wound, it's going to create a hole in the clothing. Don't cut through the hole, cut around it. And then once you have the clothing removed, you want to try to preserve the evidence that's on that clothing. So we're in a habit of anything that's bio, we put it in a plastic bio bag. Unfortunately, that doesn't do good things to evidence. It can create like a mildew effect inside the plastic bag if it's left for too long, and it can damage the DNA. So you want to try to, the best you can, let it dry in open air. The crime lab suggests putting it in a paper bag, but we don't have paper bags on our ambulances. So what I would suggest is to lay a towel down. Of course, if you have an extra set of hands. If not, then just put it on the floor. But lay a towel down and then put the soiled clothing on the towel, just so you have kind of a clean-ish environment to be putting all of this evidence, the clothing that has DNA on it, to try to preserve the evidence as best as you can. Again, it's kind of one of those things that takes a back seat, but it is still important. And then take a history. Not as much a history on like what just happened. Maybe more like, were you hurt? Where were you hurt? What kind of pain are you experiencing? What kind of vitals are you experiencing? Those kind of things. But then also get like a medical history for like their normal history, as opposed to assault history. So review. I am actually going to let you do the review on your own for this. But if you have questions, we can talk about it. You can talk with your instructor during class time. And then of course my students, I'll be there for you. So please give us give us feedback. Let us know if there are issues or if there are further questions that you have. Just shoot us an email. Let us know what you've got.